Hi, my name is Sridevi Rajeeve. I'm an attending at Memorial Sloan Kettering Cancer Center in New York City, focusing on multiple myeloma and cell therapies.
And my name is Dr. Rahul Banerjee. I'm an assistant professor of medicine at the Fred Hutchinson Cancer Center in Seattle, focusing in myeloma, CAR T therapy, and other plasma cell disorders. We're here live at the International Myeloma Society IMS meeting in Rio de Janeiro in Brazil. We're excited to be here. They're one of the big oral sessions today. One of the key abstract which was presented was the CARTITUDE-4 study, which is a study of Stilta-cel, also called Carvykti or stiltacabtagene autoleucel, a type of CAR T therapy versus standard therapies, showing that in lines 2 through 4 of therapy, CAR T actually not only led to patients being in remission for longer, improved PFS, but also improved overall survival as well. So it is first CAR T therapy in myeloma to demonstrate an overall survival benefit in lines 2 through 4. There's debate in the field, actually true debate in the field, about who needs CAR T in line 2 versus 3 versus 4. And so we're here to debate that topic. In real life, we agree on most everything,
Correct.
But we'll try to make this fun for the audience.
Yes. So, I will be taking the contentious topic of, yes, it is, we should be considering CAR Ts in earlier line settings, meaning from line 2 to 4. And Dr. Banerjee here will be talking about why it's a good idea to probably reserve CAR T for later lines. Mm-hmm. So, we can hit the ground running. So as Dr. Banerjee said, there were two main phase 3 studies that came out that showed the survival advantage, both progression-free and overall survival advantage for CAR T cell therapies. Specifically, idacabtagene viclozolin or ide-cel was shown in the pivotal phase 3 KarMMa-3 trial to have a PFS and OS advantage for patients those who had two lines prior. And stiltacabtagene autoleucel was shown in the pivotal phase 3 CARTITUDE-4 trial to be beneficial in patients who had at least a minimum of one line of therapy prior to be beneficial, and showed a benefit in both progression-free and overall survival. Now, the whole argument hinges upon, now that these trials have shown its efficacy and a favorable safety profile in earlier lines of treatment, should we be actually doing this in clinic? And, while we agree on most things, and because it is imperative that I argue for it, my argument is going to be, yes, we should be considering CAR Ts in earlier line settings. And here are a couple of reasons why. So if you look at how patients with multiple myeloma progress, like the initial way we all treat is an intensive phase called induction therapy, followed by, for those who are eligible, stem cell transplantation, or those who do not wish or are ineligible, we go for a more intensive induction therapy, followed by a phase of maintenance therapy. Patients who relapse afterwards have shorter intervals in which they are responsive to each therapy. And then by the time patients reach, for example, the 5th line or 6th line of therapy, we do not have, unfortunately, if we start off with 100 patients in 2000, by the time we are reaching 2024, we do not have as many patients. And this loss of patients at each relapse is called as attrition. By the time we reach subsequent lines of therapy, a lot of patients will not have lived that far along. Their disease would have unfortunately overtaken. Their disease biology changes in the sense that they have been exposed to multiple different types of treatment, and they become resistant, and they have resistant clones, therefore making it much more difficult to treat. And thereby, you're kind of depriving patients of this extremely efficacious therapies by withholding to a later line of possible benefit. Now, in almost all forms of treatment of cancer, the approach should be to put your best foot forward. So you go with the induction therapy that makes the most sense to patients, within the limits of tolerability, but that which can achieve the deepest form of remission status. And so why should we not carry forward that principle to earlier lines of treatment? Because at first relapse or second relapse, you need to hit the myeloma or their cancer with the form of treatment that has been shown against other second-line treatments to have much better overall response rate, a significant advantage of progression-free survival and overall survival. Now, granted, there are caveats of CAR Ts not being accessible to all, and there are significant wait times or slot allocations, and then disease really progressing as one waits for the manufacture of CAR T, etc. But if one can get past all that, the best option that is now almost definitively been shown to be much more superior to a lot of the standard of care second line or third line therapies is CAR T cell therapy. So my argument is that we should be considering that and offering it to patients.
Okay. Very well stated. I'm nodding again because I agree with Dr. Rajeeve on just about everything. The nuance that I'll add is that truly in my heart, I don't think that CAR T therapy needs to be used as second line for everybody in the US. As you mentioned, obviously, globally CAR T, there are a lot of issues getting access to it, even within North America. I think there's two issues with, I think, jumping to second line CAR T for all of our patients. When I say second line, I mean at first relapse, the myeloma first starts to come back. I think one, CAR T, as you alluded to, is logistically a lot. I think I often tell my patients that the time footprint from the moment that I first talk about CAR T with them to after 28 days after getting CAR T, we can return home, can often be like 4 to 5 months. That's a lot of time. And so where I practice, I have a lot of patients from Idaho, Montana, Alaska, Eastern Washington. And so for them, CAR T is there moving to the city, uprooting their life, taking time off from work. Them and their caregiver is often required for CAR T therapy. That's a lot. Are some patients with what we call functional high-risk disease biology, where the myeloma comes back sooner than expected, like within 18 months of starting frontline treatment? Absolutely. I would say CAR T, this is what they need. They need something novel. But for a patient who's gotten several years of mileage out of lenalidomide maintenance, doesn't live close to a CAR T center, and is wondering, should I uproot my life and get CAR T now versus get a regimen like ISA-KD, isatuximab, carfilzomib dex, or DARA-KD, daratumumab, carfilzomib dex, something like that, many options. I would say that the risk-benefit ratio actually favor getting the treatment that close to home, continuing your life, and then saving CAR T for later. The other thing is that CAR T therapy is constantly improving. Cilta-cel, as the CARTITUDE-4 study, again, has this overall survival benefit. In that particular study, there was no crossover allowed, meaning that the patients who didn't get CAR T, it wasn't part of the protocol to give them CAR T in the other arm getting standard treatment if the myeloma came back. We don't know if second-line versus third-line CAR T is better in that particular trial. CAR T does have some potentially long-term side effects. You'll hear about this in other videos on HealthTree for sure. They can cause like infection risk. There are rare cases of what we call delayed motor neurocognitive toxicities. Very, very rarely, like less than 0.5% of the time, patients can get, from Guillain-Barré syndrome, which can be weakness, or nerve palsies, or even Parkinsonism, where it looks as though they have Parkinson's disease. Those are tricky. And newer CAR T therapies are on the horizon. There are other data being presented here with allogeneic CAR Ts or rapid manufacturing CAR Ts. And so a lot of, because these newer treatments are available in a couple of years, one could argue that why rush to BCMA targeting CAR T therapy now, when in reality you could wait, stay close to home, and then in 2028, when the myeloma decides to come back, at that point, get the best CAR T available in 2028. CAR T therapy has come a long way since its initial approval. I would still say it's in its teenage years. It's a little bit impulsive, some long-term side effects, and we have some work to do to make CAR T safer and more accessible for our patients.
Absolutely agree with, again, everything Dr. Banerjee said. Every patient who comes to our clinic at first relapse, while, patients, thanks to HealthTree, are extremely well informed, they do come asking us about CAR T. So we have an overall, comprehensive discussion of what are the options. Yes, CAR T is indicated, but is this the right treatment at this time for them? For example, as Dr. Banerjee said, if someone who has had a significantly long time on their maintenance and the disease biology as we know it is not that of very aggressive, or they're not functional high risk, perhaps it's a good idea to keep CAR Ts for a later line and really try to get more mileage out of a very effective another second line dose. So it's very much of a nuanced discussion. And, we don't need to go all the way to the West Coast of the US. In my own practice in New York City, I can say that I do have a clinic in New Jersey as well. My patients in New Jersey do not want to come to New York City all the time because, again, uprooting from a neighboring state, which is hardly 50 miles away, and coming to the city is quite a lot for patients and their caregivers. So again, they do sometimes, even though they discuss about them, when they hear about the logistics and the timeline, and sometimes for working people, when they think that they have to take time off work, often they do choose to not go to CAR T. So it needs to be a comprehensive discussion with your healthcare provider, with your caregiver, and even within yourself, if CAR T is right for you at this time. So just because, and as my boss, Dr. Usmani, very recently talked at the Soho meeting in a very catchy but very prominent meme that went all around. Just because you can do it needn't mean you should do it. But we will try to do the best we can for patients and continue to have these discussions.
Yeah, Dr. Rajeeve's on point. I mean, the final parting thing I'll say about this particular topic is that definitely it's worth, as you said, discussing CAR T. I think that's the most important part, being informed about it. By virtue of watching this video, you probably watching this are very familiar with CAR T, have learned about it, the toxicities, how it works, the efficacy, etc. I would say that because CAR T is constantly evolving and getting safer and more effective, we have clinical trials of adjunct therapies to make CAR T work even better. I think it's always worth discussing with a CAR T capable center, having a referral with them just to get to know them and for them to get to know you. I would always encourage that because, as many of you know, most patients with myeloma are not primarily followed at a CAR T center. They're followed in the community by an oncologist who's much closer at home, treats all kinds of cancers, knows them the best. We know CAR T the best, and so we're happy to help out. So I would say, if you're watching the video and you're like, I'm not having a relapse. Should I even talk about CAR T now? Yes, we're welcome to come see us and at least learn more about it, get on our radar, and that way when the time comes, hopefully never, but if the time ever comes that we need to talk about a next line of therapy, we're ready to hit the ground running.